Please invite Professor Benjamin Chua from Singapore with title Endovascular Treatment for TAAA, Pitfall and Complication. Please.
Thank you very much again for the kind introduction, Mr. Chairman, and again, very honored to speak among very esteemed colleagues. I think the last few talks, everyone has showed how successful their cases are and how spectacular their results are, which is really wonderful. But what I'm going to share with you are the cases that have gone terribly wrong. And this is and the lessons learned from these very hard cases. And not a lot of people like to discuss their failures, but I think there were a lot of important lessons learned from some of these cases. So we all are quite familiar, and we discuss a lot about TAAs. And open surgery obviously is what is preferred in some centers with a lot of experience. But we know it's a big operation, sometimes a two-cavity bypass is needed. And so many people have now decided that maybe the branch stent graft is the way to go to treat these options and difficult aneurysms. And a typical graph would look like this, and I'm sure many of you do this. And a typical successful case, and which we all endeavor to do, would be one where everything is planned, everything is aligned very carefully, like this gentleman. He has a very strange aneurysm that basically abuts on all the visceral organs as we come down, and I mean the visceral arteries. So obviously we plan this graph quite nicely, and then we do our necessary aortograms and positioning. I'm not sure whether this will play. Sorry, can you play this or not play this? Sorry. Yes, so a typical case would be this, where we position our graph very nicely according to the markers, and then we release the graph, and then we, once it's fully deployed, we take our time. Usually I start from the renal branches and then I work myself up. I usually use one vessel access, usually the brachial artery, and then I take my time and just do all four quite nicely and smoothly. And that kind of sums up the case. I remember I learned this actually from going to Queen Mary and watching Professor Cheng do this, and learned a lot from him in doing this. And so it's actually a very nice way to do a graph, and if it's planned very nicely, everything goes very well, we feel very good about it. And in this patient, he had a replaced right hepatic as well, so we stented that as well, so it became a 5-branch device. And then obviously when you complete it, sometimes you see a type 2. In this case, we decided to leave it alone. So the key steps for a very successful branch graft would be good planning, understanding the anatomy and good imaging. I think the iliac access for graft deployment is important. We don't talk about it often, but if you have a bad iliac, it's sometimes very difficult to shove a graft up and you run into trouble. And then obviously when you deploy the graft, your location of branches of the graft in relation to actual visceral branches must be accurate, and the opening of branches for cannulation. And I say this again because in the subsequent cases you understand why things go wrong. The access for branch cannulation, people used to do two accesses on both brachials. Some people do 3, including the axillary. We like to just do 1 and take our time. There's no rush. And then obviously when you bridge the graft, we try and do a one-piece bridging graft, and something that's able to withstand respiratory changes and movement over time. And then of course, finally, you have endoleak issues which you need to deal with. So this is one of the cases that we learned a lot of the lessons from. As you can see, this looks like a fairly straightforward aneurysm, a juxtarenal in this patient, 64-year-old male, hypertension, heavy smoker, back pain for 2 weeks. So it was a contained leak. We decided to use off-the-shelf T-branch device with good iliac access. There were of course concerns of the SMA and celiac at 12, 1 o'clock position, the right renal at 8:30, left renal at 1, 2 o'clock. And there was thick neurothrombus, so obviously there were concerns about distal embolization to the viscerals and down the legs. So we positioned the T-branch appropriately, or what we thought was appropriately, about 15 to 25 millimeters above the visceral artery orifice as best orientation. Now, bear in mind, when you do this, you have to cater for 4-vessel orientation. And in this case, the left renal artery was not in a normal 3 o'clock position that we'd like. In any case, we figured we could compensate it by going a little bit higher and using a longer bridging graph. So we deployed as planned. And then we do our routine of a single upper limb access from the left brachial, and we cannulate it from the renal arteries upwards. So from both left and right, and we bridge them with the B graft. It looked fairly straightforward. We got in quite fast, got in and bridged. And then when we came to the SMA and the celiac, then we found that we were able to stent the SMA branch, but were unable to cannulate the celiac no matter how we tried it. And then we realized that there was a problem with the positioning because of this whole way we deployed the graft. So we finally realized that because we introduced the stiffness from cannulating the renals first, the whole graft became very rigid, and the celiac alignment went off, and we couldn't get in. And so as a result, we did an angiogram via the SMA branch. We checked the backflow. It was actually, fortunately, a patent GDA back into the hepatic artery, and we just plugged the celiac branch with an amplatzer, and then we left the residue and the leak, and then we decided to come back another day. So the lesson learned was that the orientation of the graft in a slightly aberrant anatomy, we orientate according to normal anatomy. In this case, we have orientated the graft according to the celiac and SMA instead of the renals. Clearly, the B grafts into renals could have made the whole stent graft more rigid and changed the interaction between the celiac branch and the celiac artery. And so in this case, we managed to bail ourselves out with, fortunately, a backflow from the GDA, and we plugged the celiac branch, and then we came back another day to deal with the endoleak. Case 2, smoker, hypertension. This one is a little bit more complicated because he had CKD with a baseline of 210, and he had previous ascending aortic repair with a Bentall procedure, previous laparotomy for colon cancer, and then increasing abdominal pain. Obviously, the orientation of the SMA and the celiac appears in the normal 12, 1 o'clock position, the renals in 9 and 3 o'clock, and there was also a very atretic left renal artery. And in this case, we proceeded to plan for the case based on a non-contrast scan because of the impaired renal function. So the plan was to do the case with a CO2 contrast off the shelf branch device, left brachial access for branch cannulation. We'll attempt left renal artery cannulation, but prepare to sacrifice as already atretic, and then we use the B grafts. So you can see the orientation according to renal arteries and SMA. The CO2 contrast, as you know, for renal arteries is not very well visualized because it rises forward. So sometimes we do a head up or head down, depending. And so we orientated based on what we could see. So we orientated according more to the SMA. So the SMA cannulation appeared to be fairly straightforward. We noted that the SMA was a bit stenosed at the orifice and perhaps a branch a little too close to the orifice of the SMA with heavy respiratory movements. And we saw a small kink in the bridging graft post-deployment. We noted that. And then, as expected, we were unable to cannulate the atretic left renal artery, so we decided to sacrifice it, and we focused on stenting the right renal artery. So we blocked the left renal branch with an amplatzer. Looked fairly okay. Then there's a problem that we couldn't locate the celiac. We had a lot of trouble. Sorry, can we, how do we go back? Yeah. So we had a lot of trouble trying to locate the celiac axis. Spent 1 hour trying to cannulate. We attempted to percutaneously come in from the hepatic artery access retrogradely to pass a guide wire. We failed. The angiogram showed essentially flow from the SMA into the GDA and back to the hepatic artery and branches. So we were kind of relieved that, okay, at least we got 2 out of the 4 branches, and not too bad. And so we decided, okay, since we have a backflow from the GDA, from the SMA, we also plug the celiac artery and terminate the surgery due to a long procedure. It's getting very painful, and also painful for the patient. However, we started the patient on dialysis, obviously, because 1 kidney was gone. And then the patient developed severe abdominal pain and acidosis. Sorry, can we play that again? Can we play the videos again? And when we went back, we realized what the problem was. The problem was that the SMA stent, the bridging graft, had thrombose, and there were distal emboli to the branches of the SMA. Again, we saw what the problem was. It was actually that kink that we saw initially that we had stented across, and we had assumed with a balloon expandable stent would have sorted itself out. But clearly, the respiratory movements caused the stent to crash again. So if you can play the videos again. Sorry. So we saw that kink, we saw distal emboli. So we did what we did. We went in, we did some thrombolysis, and then we restented with a self-expanding stent. Then I laparotomized the patient. However, he had ischemic liver, bowel, small bowel, and stomach, and he passed on 1 hour later. So what was the lesson learned from this? The position of the graft was suboptimal. Clearly, the SMA and the visceral orifice was too close. The bridging graft was crushed by a muscular stenosis of the orifice, as well as a graft interaction with respiratory movement. Should have considered a reinforcing self-expanding stent. And clearly, the celiac artery branch was also suboptimally positioned. I keep asking myself, could we have converted to an open repair, maybe iliac artery to a visceral artery bypass? Not so sure, because the case was getting too long, patient was getting too sick anyway. Third case, 67-year-old male, history of smoking, hypertension, persistent back pain. If you look at the scans, they look fairly straightforward for a off-the-shelf device. I mean, the viscerals are in correct orientation. But in hindsight, we realized that there was a hard shelf of plaque just superior to the left renal artery orifice, just there. Okay. So the anatomy, celiac SMA in customary positions, right renal 10, left renal 4. Right kidney has accessory renal artery. It's supplied to half of the right kidney. A lot of extensive mural thrombus. So we didn't feel that that shelf above the left renal artery would affect graft deployment. So we went for off-the-shelf device and left brachial access again. So initial angiogram looked okay, and we used the renal arteries and SMA as landmarks. We deployed the graft about 15 millimeters above the visceral artery orifices. Looked fairly normal. What we didn't expect was that hard calcified plaque above the left renal prevented our access to the left renal artery. So we decided to stent the SMA first as a safeguard, and then change the strategy where we cannulate the left renal artery from the right branch and hopefully the right renal artery from the left branch. However, during the procedure, there was a perforation of the left renal branch artery, as you can see, with a drop in the BP. So we were unable to drive any balloon or stent into the left renal artery, so we decided to stent the right accessory renal artery to try and save one form of kidney from the right branch. As you can see, however, things went horribly wrong. The stent fractured, it dislodged. And on top of that, we finally managed to restent the right branch to the accessory renal. Then the BP started to fall, and we noticed a large bleed from a rupture of the right accessory renal artery. And this was probably caused by the wire. So we had no choice but to embolize the right renal artery to stop the bleed. So at this point now, we had no renal artery left on either side. We had no access. So we decided to stent the celiac axis quickly and send the patient for dialysis with the hope that there would be a backflow or integrate flow back to the SMA. And the completion angiogram didn't look very good at all, as you can see. So initiated our hemodialysis, worsening the acidosis, and he died 12 hours later. What did we learn? That one small hard plaque that we didn't appreciate in the scan caused so much misery. Should we have stopped when we ran into difficulties, especially after attempting to stent the renal arteries at many stages, or could we have converted to open explant? I have no answer for that, except that it was a very difficult moment and case. And so that hard plaque was actually what caused a lot of that misery, as you can see here. So in conclusion, the branch graft repair is ideal for most TAAs. Understanding anatomy and aneurysm and relationship with branch device is actually very important. You need to predict the interactions between the graft and the actual visceral orifice, but sometimes it's very difficult. There are nuances that you need to know, and you need to prepare bailout options, and obviously consider alternative options if the device doesn't fit. Hopefully with intra-op fusion technology and preoperative 3D printed aorta, we may get better at this. Thank you.